That's a lot better voice than mine. Welcome back for lunch. I voted for a siesta time, but it was voted down. Yeah. No comment. Okay, that moves us along, committee, task force. To the 1 p.m. the number 6 item on your agenda, vulnerable adults. And I believe we have the graph ready we can put up that we prepared. And what we'll do, committee, is we're going to work our way down through that, talk about it, vote, comments, etc. And what we're going to do, this is not a bill, but we will vote on it conceptually as what we will support and recommend as policy recommendation out of this task force. And I apologize, I don't have that in front of me and I can't see very well. So if somebody got those, so I knew I could count on Senator Barlow. Here he is. Barlow wins. Okay, committee, what we'll do is let's just go down through these one by one. Or if Director Schmidt, would you like to take us through these and just work through them one by one and we'll comment and then at the very end we'll take a vote on them. Thank you.
Absolutely, Mr. Chairman.
Go ahead, Mr. Chair.
So, Mr. Chairman, this is the final form based on everything that we've done, I believe, in Torrington, where we had voted to move stuff, and we just asked them to refine this so that then we could give the agencies direction once they got this refined product that we're looking at today, and then start looking at existing programs, how we can use what we currently have and maybe make some suggestions on bill drafts in the next interim.
Perfect. As you told us before, very much a work in progress. We make recommendations, go back to the agencies and see what they come up with. Go ahead, Director.
Thank you, Mr. Chairman, Mr. Co-Chairman, for that kind of overview. This is a work in progress, and I actually see this as a work in progress for a long time. As we've mentioned before in these conversations, this population is growing in Wyoming. The elderly population is becoming a larger part of who we are. And then just with that, just demographics are going to hit and we're going to see more vulnerability. So I very much have appreciated this committee's work on trying to establish a policy because it is a place where in the communities, there's a lot of confusion about who should do what. And I recently had a conversation with a community in a hospital and the hospital asking us why the agency wasn't doing more and why we weren't providing housing and why. And so this conversation has been very helpful to have conversations with communities about really what the agency can or should do, the state can or should do, and then locally what should be done. So it plays out in real life every day. And I think the continued conversation to refine these is going to just be very helpful for all the systems that engage with this population. So to kind of recap, conversations that started in Cheyenne continued in Kemmerer and then last time in Torrington is really filtering down the proposed essential services. We started with a very large spreadsheet with a lot of information about who does what and have really brought it down to what we hope is a more simple way to talk about what we believe is essential and who should be providing those essential services and where. So on the left-hand side, you see proposed essential service, the state role, which was really the meat of the conversation in Torrington, and now really who's responsible. And thank you to Anna and the LSO for drafting this because that conversation was really confusing. And so being able to capture all of that was very nice. Thank you. So the first one is housing, and the conversation about housing came up, of course, today as we were talking about the diversion program. Housing comes up in many of our conversations, but it's a little bit trickier when we're talking about vulnerable adults. A lot of times we're talking about elderly people who need wheelchair access. We need different kinds of modifications to buildings to housing in order to be able to best support those people so that they can stay at home. So it's even narrower and even more complicated and less available when you start to look at our vulnerable populations. However, we also recognize that there's not a single solution. And what we ultimately decided is that this really still belongs as a local conversation. Certainly, there's a lot of state level conversations happening, but at the end of the day, it's up to communities to really try to do the best to serve the people who live within their communities. So that was the state role, certainly doing better with leveraging the existing programs, knowing more, understanding more, working closer with our partners, establishing partnerships. But that the state has somewhat of a role, but it's really at the community level.
Very good. Any discussion on that item? Committee members, Senator Barlow.
Thank you, Mr. Chairman. So this one actually, the proposed essential service actually presumes that folks are not homeless. And then when you get to the second column, just the way I read it, you get to the second column, then we're talking about an emergent. Well, often homeless people, that's not an emergent situation. That is
Reality.
something else. It's a reality, and so I don't know what I just want to point out though that I think when we look at vulnerable adult not living safely at home, we're assuming they actually have a home, and we're assuming that there's, the vulnerability is in that environment. So there's some nuance in, I guess, homeless or the home part of it. And I don't know I just don't know how to tie it in my own mind with the emergent need. I guess that's a case, that is case by case, I guess. That's maybe the easiest way to think about it for me now at this point. But the last one, who's responsible? That's where this home versus homeless, et cetera. If it's someone that has a home, is in a dangerous situation, et cetera, that's one thing. If it's someone that doesn't have a home and et cetera, then we get to a different dynamic. So anyway, I just throw that out there. As you know, it's a national topic about homelessness. There's a national topic about housing and inadequate, not good housing, but no housing in many communities, including some in Wyoming. So anyway, I just throw that out there that as I read this one particularly, it struck me that there's kind of an interesting dynamic, and we're going to have more vulnerable adults in the homeless population if all things are said and done. Thank you.
Mr. Chairman, go ahead.
So my question then would be to Director Schmidt or to Director Johansson as we talk about safe places temporarily in existing programs. In the conversations that you had as putting this document together, I would assume that you would look at existing housing needs that or existing housings that maybe we have in our community mental health providers that provide some of that temporary housing, and perhaps that does that need to be expanded? Is it long-term care? Is it more, how do we better leverage community choice waivers? Or are you just some enlightenment on the conversations you've had?
Director Johansson.
Thank you, Mr. Chairman, Co-Chairman Larson. So on this, kind of recapping briefly the discussion in Torrington, and then Director Schmidt and I had some follow-up conversations in the meantime between then and this meeting. The theme that I think you'll hear across the board on these, and certainly see in the document that was put together, the task force really felt that on every one of these categories, there is a state role. I think that's what we wanted to establish up front in Kemmer and in Torrington. But the subsequent question should that role be expanded to ameliorate some of the issues that we see in vulnerable adult cases? And that theme that you'll see from our Torrington discussion is really not an expanded role, but leveraging existing resources within current eligibility frameworks like Medicaid waivers, Department of Health programs through senior centers, and DFS casework. And I won't speak to that, put words in Director Schmidt's mouth, but with safe housing, and to Senator Barlow's comments earlier, the example I like to think about, because I think it's somewhat common in the casework, is a referral's made, potential adult protective service case or potential vulnerable adult, and the house itself, the living environment itself, for whatever reason, is not safe, not suitable, dangerous, or as Director Schmidt mentioned in Torrington, sometimes the cohabitants of the house itself are creating the vulnerability or exploitation or abuse. So the program strives to and often provides through DFS temporary emergency measures to make sure that in this brief time period, safe housing, even if it's a hotel or some sort of temporary living environment, can be arranged while the other issues are worked. And from my recollection, and I think you see it included in the notes here, task force's discussion was, yes, that's an appropriate state role and potential. Again, I'm over my skis here, but potential need for resources going forward as the population grows with our older adults primarily. But when you get into, home repairs or environmental modifications or assistance with locating housing resources, that's where some programs around the state, mostly in the Department of Health through home-based services and senior centers or the Community Choices Waiver and Medicaid, or now with our community behavioral health redesign, those are specific populations and eligibility criteria that I think this can inform for vulnerable adults that might be identified versus a new expanded function within adult protective services in DFS. So again, just summarizing some of that theme, you'll see that across many of these categories of leveraging better, having better awareness and potentially a longer term plan between the agencies, that when vulnerable adults are identified, we are better at connecting those eligibilities and resources, knowing full well that within those eligibility parameters of certain programs, not everybody qualifies. It depends on age, sometimes acuity level, medical need, and financial income assets or resources. So Director Schmidt, I don't know if that's a fair summary, since your folks are doing the grunt work and the on the ground work of managing these cases. But that was certainly my takeaway, that almost universally here, there's some state role, but in terms of expanding that role with new programming, most of that discussion in Torrington was, no, we need to do better with what we have. Thank you.
Director Schmidt?
Mr. Chairman, and yes, thank you for that, Director. The emergent, I think the importance is to distinguish the emergent from the long-term. And I think that is where we do struggle a little bit in communities in terms of what's the role of the state, meaning the role of the Department of Family Services in that situation. And I think there's an assumption that's made pretty broadly that the department, has authority to place an adult as we do with children, and also the financial. And we don't. We are not funded at a level where we can provide long-term housing, even medium-term housing. It really is short-term, a few days, a few nights, maybe a week or so. So it is a gap. I think that, by making this statement, though, we can really speak more to that gap and then bring in communities to say, so what is the longer term? And I do want to thank the Director Johansson about the work that he and his team have done around Medicaid and the various programs that are available to Medicaid, because that's been a helpful long-term solution for some of our vulnerable adults that are younger, that maybe are vulnerable because of their developmental or intellectual disability. So the conversation, I think, for us to decide is, do we concretely agree with this? And then maybe a conversation about, is it funded appropriately? And from the emergent side, I would probably say, no, we receive $80,000 a biennium to provide all of these services. And so while we're comfortable with understanding our role as the emergent, that emergent is also, those dollars are also spent across all things vulnerable adults, not just housing.
Very good. Further comments, committee?
Mr. Chairman,
Go ahead, Representative Summers.
Mr. Chairman, thank you. And I think both directors just hit the nail on the head as far as I'm concerned. It's that case where law enforcement has to pull somebody out of a home for whatever reason, whether they're being mistreated in their own home or whatever, and you need to have temporary emergent housing, and maybe that's a night or 2 nights or 3 nights. I don't know what the nights are until you figure out what to do with that individual or how to stabilize them. And I think this is really critical in our smaller communities where we don't have the support infrastructure that perhaps a larger community would have. And so I definitely think, you say expanded role, I don't know what expanded means. Expanded, if it means monetarily expanded, I think we do have that need to monetarily expand this need, and what that figure is, I don't know. That would be up to DFS ultimately in the governor's office to decide in a budget. But certainly I believe there needs to be a recognition about this emergent need when it happens, and we need to be able to try to fund it.
Speaker, thank you, Speaker Summers. Further comments? Committee, okay, let's go ahead and move on down to the next one, if you would, Director.
Okay, thank you. To recap the conversation around food, there's been a lot of work and there's actually a lot of interest in providing different types of food services for people who are food insecure. And the recommendation here again is to further support and refine what the state is already doing. And I think the conversation is really about doing a better job of what is happening locally and providing support to those efforts. The department received some ARPA funding to look into the food security delivery system. We recognized it was very fragile after COVID. And through the assessment that was just completed, there's an incredible amount of work that is being done. The idea, though, is making better connections between growers, producers, food distributors, such as food pantries, so that that food is more accessible, more people know about it. But in terms of an expanded state involvement, this is somewhere where the philanthropic organizations really kick in, the community really kicks in. And rather than expanding the state's role, just continuing to support those efforts wherever we can.
And you just brought to mind, I think you hit it right on the head, is getting the knowledge out there, getting the information out. And I say that because I just had a patient this week that came in that needed this exact thing. They're vulnerable adults. They do get one meal a day from the senior center, but that's it. And that's not sufficient. But there are other resources. They're just not as well known. I think that's important. Other questions or comments, committee?
So,
Go ahead.
Chairman. So to the point that you've made, our senior centers are somewhat like our community mental health providers. They have different funding needs, and what we've said is on the state general funds, these are the services that you'll provide. I think, a couple of days ago, we voted in in my town to form a senior center district and to assess a 2 mil levy tax, which would go a long way to help those centers provide services. And I think one of the things that we'll ask the agencies then is to look at the state funded dollars for these entities that provide services to vulnerable adults and say, maybe we have a similar conversation for these state general fund dollars. How then do we get more meals out to vulnerable adults or whatever the case may be? And so I think that there's some opportunity to rethink how we currently structure ongoing operations and maintenance of some of these entities, and then reprioritize what we use the state dollars for. And I look forward to seeing what this looks like. Thank you, Mr. Chairman.
Good. Further comments?
Mr. Chairman,
Go ahead, Speaker Summers.
Mr. Chairman, thank you. One concern I would have about redistributing dollars is you get into these smaller communities, and I think of the LaBarges or Big Piney or whatever, and maybe they're not going to be able to form a district that would be able to do anything effectively. And so I worry about redistributing. And frankly, I wonder if, this is another case, I wonder if these entities are not underfunded from the state. That doesn't mean that I don't disagree that they should form districts where they can, but I'm not sure that districts are the answer for every place that there's one of these senior centers in a small town.
Mr. Chairman, go ahead, sir.
And Mr. Chairman, and I agree with Representative Summers. I'm not implying that that's what happens. I just think that this provides us the opportunity, given all of those different scenarios that are out there, to look at the allocations we have and see if we can't use them more efficiently. That doesn't mean that I'm trying to, I'm suggesting that that's what we're doing right now. And I think we have to be careful not to, I think we have to let the agencies have some flexibility to look and make some recommendations to us and not, let's not put the hobbles on them and say, well, you can, but you can't look at this pot or that pot. I think we need to look collectively at all of these programs and then come back and the legislature will make a decision whether it be appropriate or not, and it'll have to be with those stakeholders' input.
And I agree with that, Mr. Chairman. I would say further what Speaker Summers, that one size doesn't fit all. Each of these communities is way different. Labarge is different than Casper, is different than Saratoga, is et cetera, et cetera. And so that needs to be an important part of the conversation. Everybody can't form a district. There's other solutions. Philanthropy is a solution for part of this, but further discussion. Seeing none, go ahead, Director Schmidt.
Okay, moving on, Mr. Chairman, medical care. Yes, we believe this is an essential service. However, there are services out there. I think the essential part comes in, again, temporary, a temporary either place or some sort of, I don't want to say emergent necessarily, but somewhere, somehow, people can receive some medical care until they can transition into one of the programs that's already available. For this population, really what we're talking about is Medicaid, a Medicaid program, more than likely. And so the temporary care that they may need before eligibility can be determined and enrollment, et cetera. The way that we look at it is a lot of the people we engage with are already enrolled in some sort of program. Sometimes, though, it is that time period between identification and then getting them signed up for benefits. That's somewhere where we could use our budget, but again, it's a limited budget. And so those emergent services, we can go through $80,000 pretty quickly. But this is a place where we really do lean into the other systems and let those systems then provide the care. Access to medical care, as we've long discussed, is an issue for all of Wyoming, and it's an issue for this population as well.
Mr. Chairman.
Go ahead, Mr. Director.
Thank you, Mr. Chairman. Just to add to what Director Schmidt mentioned, medical care generally, as she rightly pointed out, we have programs managed in the Department of Health, largely through Medicaid, but others as well, that there's a wide range of potential needs here when it comes to medical care, depending on the situation that a DFS caseworker, someone who's responding to the referral, discovers. For your over 65 population, generally speaking, the primary coverage mechanism to pay for services is Medicare. But then under that, and sometimes within that, you have developmental disability diagnoses, you have potential nursing home qualifying applicants who might qualify for in-home services through our waivers, et cetera. This to me goes hand in hand with the next topic, which is transportation, because we're often talking about someone who might be neglecting their own needs or their caregivers are neglecting needs. And so there's a medical issue. Wound care comes to mind that is discovered from time to time, or diabetes management because someone is not filling or taking their insulin prescriptions. And it's about connecting that person to that medical resource and where that is. So on a smaller scale, medical care here goes hand in hand in my mind with transportation. And again, task force seemed to indicate there is a state role here, generally between DFS and the Department of Health. And my contention is that for us, certainly on the health department side, to continue to improve and do a better job with making sure that the folks in the field know what services, programs, coverages are available generally to pay for things, but then connect this medical care issue with the transportation, the transportation issue, which we will discuss next. Thank you.
Further discussion. I would add to that is I don't think it's just those two that are connected. I think if you take a whole page, they're all like this, right? Because food, a diabetic, that's a vulnerable adult. If we don't get the food right, the medical's not right. And if they don't have the means to get to that appointment, et cetera, et cetera. And I think they're all connected. Go ahead, Director.
And Mr. Chairman, to add, you're 100% right. And to add to that, I think across all of these domains, I mentioned, Department of Health, education, resources, et cetera, for caseworkers too, because it's always evolving. It's always different in every community of what's available. How quickly can an application be processed? How do you do that? There are ways to improve there between government agencies, which Director Schmidt and I discuss often. But to your point, I also feel like our various systems and funding and programs, since we've had this conversation at this task force, can have a better awareness going forward of what a vulnerable adult is and what an adult protective service case means, so that when Corin staff is reaching out, because we've educated and say, hey, you should call your local mental health center because they're now an eligible population under behavioral health redesign, or you should refer to or call X, Y, and Z. There's not a lot of context for now that receiving entity of what a vulnerable adult is. I think this task force establishing over the past year this discussion up front helps us do that as agencies. But when you think of DD or long-term care waiver providers, community mental health centers, senior centers is a big component of this. Us being able as an agency to define vulnerable adults may come to you in this way. Here's what these cases mean, and here are the expectations. I think we can do that as this task force puts a policy recommendation out that helps us define sort of that. It's not a program, but almost a system or a matrix of services that helps our providers or the folks that we fund and contract with expect service in a different way, if that makes sense.
Very good. Further discussion, Director? I say director and everybody's in here, right? You ever see that movie, Spies Like Us? They say doctor. Yeah, kind of same thing, Director.
On to transportation, and I'm going to go ahead and beat this dead horse because I think it's really important, but transportation and the linkages between all of these programs. And I think the conversation has really taught us or highlighted for us the money that comes to the state through various resources. For example, with this, the Department of Transportation is a big recipient of funds that then are utilized by local communities to provide transportation. I think that's a really good example of where the state, and what I mean not at Wyoming as a whole, but where state agencies could do a better job of understanding and setting the communication and understanding and setting the policy, so that locally, when those dollars are distributed, they're distributed understanding that there is a target population or a certain population that affects all of our systems, and that may be looking to those dollars to help solve some of those problems. So it's multi-layered, but the work really happens locally. And I think the other lesson is that while we at the state level like to think that we control the world, we know we don't. And the relationships and the decisions that are made locally is where the work gets done. I would say, if I were to argue from a local standpoint, the state could do a better job of organizing those dollars and those the expectations in a way that we're more aligned. So it's not just a little bit of money going everywhere. It really is trying to think about the problem we're trying to solve. So transportation, I think, is another good example of that. We've learned that there's money that is available through a variety of resources. To be honest, I had no idea that the Department of Transportation provided that kind of money. I mean, obviously, I know that they provide money, but for specific populations. So right there is a good conversation to have, to say, how are we doing for, how were those dollars being used to support vulnerable adults? So that is the conversation, I think, in terms of transportation. One other added element, and this came up again today in the conversation with the diversion program, transportation for people who maybe can't transport themselves and need additional support in that transportation, whether it's a vulnerable adult who needs wheelchair access or some sort of mobility issues. And in the case today, it was somebody that was in a crisis, a mental health crisis that needs to be transported from a community to a treatment provider. So transportation, not just in town, but transportation out of town as well.
Comments committee. Okay, you beat that dead horse well.
Okay, great. Thank you.
Okay,
Case management. Now, this is really where the department comes in a big way. And the Department of Family Services has available in every community caseworkers who work with communities on adult protective services cases. Also available in every community, although they work very differently, are adult protection teams. And it's through those two mechanisms by which we can do a lot to identify what's available in a local community, what's not, how the community agrees to work with each other, including law enforcement, medical providers around adult protective services issues. But this is where a lot of the department's work is done. The difficult part has been and will continue to be, I think, for a while, is defining what is the role of the Department of Family Services in regard to vulnerable adults. And through this conversation, we recognize that there's a lot of gray area. It's not nearly as defined as it is with a child, where we have laws and rules that direct how we do our work. Our vision for adult protective services is that we're there to get in, to stabilize, to provide support, and then let the community take over the rest. So much of what a vulnerable adult needs long-term, the agency is not in a position to support. And as a policy person, I'm not sure that's the role of the agency to start. So as we think about case management, we think about it in terms of really time limited maybe, but certainly a shorter duration than maybe what you would see with a family in terms of child protective services, but really getting in, helping to stabilize, helping to make the right connections, whether it's to family, whether it's to other resources, whether it's to other case management. So then we can step out, communities can step in, and people can continue to live their lives as adults see fit.
Chairman, go ahead, sir.
Director Schmidt, is this the? No, I'm going to wait, Mr. Chairman, to the next one. I just seen that's the one that's triggered my conversation. Thank you, Mr.
Okay, hold that thought.
Hold that up.
Go ahead, Senator Barlow.
Thank you, Mr. Chairman. So my query is in this particular state rule discussion, there is a statutory something, there's some statutory nexus to this timeline. So I guess my query is there a statutory nexus to how long case management currently takes place? If there's not, then we're really talking about maybe funding or or some other kind of authorizing mechanism. So I just want to understand, is there a outline? Is it in statute how long you can case manage? That's the first one. Thank you, Mr. Chairman.
Director.
Mr. Chairman, Senator Barlow, in terms of case management, no, there isn't a statute item, and I'm looking to my team. There isn't a statute that defines it. In terms of regular practice, what the data tells us is that our typical engagement in an adult protective services case is less than 6 months. But that's going to be shorter in some communities where there's maybe another system that can step in longer in other communities, or with cases where there's absolutely no family members. And it's just really tough to identify. What I think Mr. Co-Chairman is going to get to is the someone who cares. And again, that's another responsible party at some point that can help that adult make the decisions and continue to provide support to them long-term. And then the state then doesn't have to manage somebody's personal affairs for a long time. So there's no statutory definition. It's just by practice and policy that we really do try to look for other supports so that then we can close the case. The statutory reference, I think, for this is probably the emergency services, which is the court ability to have oversight for 30 days, and that was the change that we made last year. And I'm looking to Anna, but I think that's probably what the statutory reference means. Yeah. Mhm.
Thank you. Further discussion, committee? See none online. Go ahead, Director.
Okay. And then someone who cares. And this is really, the someone is not necessarily a single person, but it can be an organization. It can be somebody who is really somebody or something that then is there to help that adult, that vulnerable adult, continue the life is that they want to leave, the decisions that they want to make, but with support that maybe helps them avoid any type of further vulnerability, whether that be abuse or self-neglect or financial decision-making that could somehow hamper them. This is a tricky one because, you know, in communities and in families, that used to be family. That would be that someone who cares. But that's not always the case in many of the cases that we're involved in. Finding that someone who cares takes a very long time. It's really tough. We're doing searches for family members. We're looking to community neighbors to see if there's somebody who's willing to voluntarily step in and really be that support to this person long term. So it can be informal, it can be informal, but at the end of the day, it is an essential service.
Chairman Larson, go ahead with your thought.
Thank you. And so in my opinion, this is probably the lowest hanging fruit. And it's establishing who can help that individual legally with some of these decisions, as we talked about the guardianship and the lack of that structure in APS and lack of a unit, if you will, in that DFS budget to be able to facilitate that. I think historically we have relied on families and relied on community, and that's all great. But I think this piece really connects a bunch of the other above, the case management, the safe housing, medical care. All of that is going to be contingent upon that person that may not have capacity at that point in their life to make appropriate decisions. This seems to be one that's ripe for some, it might take a couple of swings, but I just, I hope the agency is looking at that in this supplemental budget request to kind of, as you alluded to early on the amount that, I mean, 80 grand for adult protective services in your budget is not much. And I think that we're starting to get the data and the information. And I think that to make a more appropriate data-driven request that could be supported by the legislature, and hope that we can kind of have that conversation as you guys are getting ready for that this year.
She's smiling. I think she says, okay, we'll do it.
Mr.
Go ahead,
Chairman,
Senator Barlow. Oh, go ahead, Speaker Summers.
Mr. Chairman, sorry. You know, I really agree with your co-chair. I think this one, to me, this one and the emergent housing piece are the two things we need to try to get. And I don't know whether it's a recommendation out of the task force to the department, whatever would be beneficial. But certainly this guardianship piece where ARPA money was being used to kind of prop up the program. I think we need to figure out how to fund that. And I mean, guardianship, particularly court-ordered guardianship, we need to have a means by which to fund some of that.
I would not disagree. Go ahead.
Mr. Chairman, so Representative Summers, my question to you, does that not seem like that just is something that should be part of their standard budget? I mean, we've just overlooked that, the delivery or what the agency is required to do in that statute. So I guess I'm thinking that this comes back in to just a standard budget request as part of their budget moving forward. And I don't have the dollar amount. I'm just thinking of that it's not there now, and we have definitely learned of the need. Are you seeing that differently than I am?
Speaker Summers?
So, Mr. Chairman, no, I'm just curious if a recommendation out of this task force might help or hurt, I don't know, might help the agency in that budget request to the governor. That's all I'm thinking.
Senator Barlow?
Thank you, Mr. Chairman. So when I'm looking at these things, I understand identifying but what the role of the state is, and I want to again point out in the state role, this one talks about role of guardianship role should be expanded. So let's be clear, the guardianship is a legal process. It is in the courts, it is defined. So I don't know if we're talking about actually making the guardianship have more responsibilities or we're talking about expanded guardianship availability in our system and somehow. So I think that's what we're talking about, but I just want that affirmed. And then certainly something I hear, and I wish some of our hospital folks were still here, would be is the time that it takes to get a guardianship through the court system, at least is challenging, not just availability of guardians, but the time it takes to schedule a hearing, do all the things. I think I can, and if Mr. Lubno were here, he provides counsel for our local hospital district. I think they're waiting months, if not even a year, for guardianships to be, and housing those people in a hospital setting, inappropriate setting, for that time as they're trying to establish this guardianship so they can get this person to a safe environment. So one, I think we're talking about the availability of guardianships. And then I think in that context, we also have to talk about the timeliness of that process and getting these folks the assistance that is deemed appropriate. So I think that's two things. And to that point, I think there is a budget item, a number that can be assigned to that, saying Department of Health, you get a request for a guardianship from a hospital and it's genuine, then here you can help reimburse the cost of that. And the courts, oh, by the way, courts, we need this prioritized in some way. How do we help you do that? So anyway, just two thoughts that, at least in my community, what I hear particularly from our hospital, that's two challenges. Thank you, Mr. Chairman.
Chairman Larson?
So, Mr. Chairman, I think coming back to the guardianship component, I think historically we provided funding through Guardianship Corporation through the Department of Health that's been targeted towards the state facilities. But in the conversation that has been refined through this task force, and we look at vulnerable adults, this agency's been tasked then with making sure that vulnerable adults are not being exploited, that they're doing this. And it's similar to like what we have asked this Department of Family Services to do when there's a court order placement on a child. This child needs to come and go to a regional treatment facility. We don't care if you have money for it or not. You're in charge of it and did it. And we've recognized that over the last couple of years and tried to put some money aside because they don't decide who goes to court and who doesn't. They just have to respond to the mandate of the court. And I think that we find a similar situation here where we can't really predict or assume that there's going to be a specific number of vulnerable adults that families are not available, that nobody's available, that they're stranded and are going to need some guardian decisions. And so we need to make sure that those resources are there. And I think I think that that's the point on this guardianship, is that when the courts do finally get whatever that process goes, but we need to have the resources because that's contracted out, and we need to make sure that we have the funding available that they can provide that. Now, the budgetary process will evolve from year to year. Did you spend all of that unit or not? Well, we can adjust accordingly, but we probably ought to have a certain amount there available to the agency in the event that those guardianships are warranted. Then the housing component of it is another conversation that may be somewhat similar, but that's my thought on the guardianship component of it, Mr. Chairman.
Director Johansson.
Thank you, Mr. Chairman. Building a little bit on what Senator Barlow mentioned, because I think he hit the nail on the head. You know, legal guardianship is kind of an ultimate process where you're finding, you know, someone to take on these duties of decision-making in a very legal way. And that's true for the funding that we've had, or guardians we try to find for folks in our state facilities, but it's very similar to vulnerable adult and adult protective services with the timeline, where we can do things on an emergent basis because there's an emergency and there's certain authorities to do that, fix a situation now, temporarily, et cetera. But on an ongoing basis, if someone is truly, you know, vulnerable and by definition in statute and lacks some of that decision-making capacity, then you have an issue of making those decisions for them and what's the state's authority legally and our role for continuing to do that. That's where we often drift into the guardianship discussion because they're very much needed. And Senator Barlow, to your question, what we find is it's just very difficult to find people to do that. And there's many reasons for that. Sometimes it was legal fees and the court system and also the time that it takes to invest in helping, whether it's a family member or a friend out to do that. There's a lot of investment that takes. I think two things from my perspective here, if you do have a bigger pay source to, it's an economic incentive, right? So whether it's Guardianship Corporation or any other organization that would help facilitate folks being willing to act in that guardianship capacity, then yes, additional funding, economically speaking, will likely create some additional supply, right? Because there's a pay source. We're going to put our thumb on the scale there to do that. I would recommend the task force consider whether this becomes a policy recommendation or a letter or what have you, that there's intermediary concepts between, you know, state handling it and guardianship, where now a court adjudicates that someone needs a guardian and it's this person, with the supported decision-making framework that has become, you know, not very popular, but more popular in developmental disability, intellectual disability circles, that could be replicated in this vulnerable adult context. Again, it comes down to who does that, who's facilitating supported decision-making that doesn't require, you know, a court involvement, things like that, but can be a very good process to maintain autonomy, but have assistance with making important decisions in life. And we're happy to provide some of that to LSO or to the task force. We've looked into it the past couple of weeks after the Torrington discussion. Some states have passed law that, you know, require in some contexts a supported decision-making framework, that being explored prior to guardianship. But I think the information for a policy recommendation from this task force would be useful going forward. Thank you.
Further discussion, committee.
Mr. Co-Chairman, so along with that, a lot of the work that we do is within some sort of framework similar to structured decision-making. And there are very deliberate models around structured decision-making. And the concept that we're most familiar with is really around the MDT, and that's kind of what they do, right? They, in a protective services arena, whether it's child protection or juvenile justice or CHINS, that MDT may take on a structured decision-making approach. And this maybe is a conversation offline. Where I wonder though is, you know, again, referencing the conversation I had with a hospital lately, is that that wasn't the issue. They needed to have somebody be in charge of this person, and the state could not do that. And so I do think there's a role for that in some of the cases where maybe we're not seeing such a vulnerable adult. Maybe we're seeing somebody that is potentially at risk and we want to prevent or mediate or, eliminate some of that risk and providing that support. But I also think that we need to think about the guardianships as well. To go to the point about money, we, through the ARPA funding that we received, we purchased 20 guardianship slots for $364,000. So that gives you an estimate of the cost. Not that I want to have a different policy conversation, but just so that everyone recognizes other states also have state departments that provide those guardianship services. So I think the essential services conversation is that we recognize it's an essential service. How that service is delivered is really dependent on, the body, whoever that body may be, but it is arguably, I think, an essential service.
Further discussion, committee? Seeing none, that completes the page. What I would look for here is, first of all, any verbiage changes from anybody in the committee on what you see in front of you. And lacking that, I would look for a motion to formalize this as a draft to make a recommendation.
So, Mr. Chairman,
Go ahead, sir.
I'd make the motion that we just continue this process and allow LSO to work with the agencies to craft a letter back in or to make part of these recommendations part of the report that will come back. We'll review that and put our final stamp on it.
Very good.
Mr. Chairman.
Go ahead, Senator Barlow.
I think there's a, yes, first and a second, and now Speaker Summers wants on, but Mr. Chairman, just to be clear, we're gonna refine this or potentially refine this, putting a letter form to direct the executive branch to get this done.
We have Mr. Chairman,
ahead.
sorry, we have a requirement, I believe, to provide a report back. And I think that this would be included, this part of the report.
Okay. We got a first and a second, and I believe Representative Summers has comment.
Mr. Chairman, I think in the end, we just need to make sure in the areas where we believe there's going to be needed extra resources that we say that in this report, that we believe there's a shortage of resources in whatever those areas are. And not necessarily that we're expanding our role, but that we're short of resources. I think it's important that we do that.
Very good, and absolutely agree, Representative, and I believe LSO's got that. I see them typing busily. Okay, we have a first and a second in motion. All those in favor of that motion, say aye. Any opposed, say no. Okay, that motion passes. Anna, go ahead. Oh, no, but we sure will. It'll be posthumous, as I say, but is there any public comment on these items or on the things we just spoke about? None online, none in the room? Okay, we're official. Okay, committee, we're gonna do something here just to keep you all on your toes. We are gonna jump ahead. We're gonna skip item 7, we're gonna skip item 7 for a couple minutes. And we're gonna move on to item 8 on your agenda, which is dementia directive discussion. And I do that because we have an honored guest with us who wishes to discuss that today. So, Mr. Lubno, if you want to come up to the table, let's get that bill draft out if we would. 25 LSO 0216.
Mr. Chairman.
Go ahead, sir.
So, Mr. Chairman, as we're waiting for our good friend, Mr. Lubnow, to come up, I would just remind everybody, I believe it was in our last meeting where we had the Alzheimer's Association come and talk to us about the need of expanding the language in advanced care directives. I believe the good former speaker was the author of our current advanced care directives and was the one that kind of brought this to our attention, that as you could possibly read into our current statutes the ability to do this covering dementia, but further refinement would add clarity to that, has worked in helping to give us some advice on some language. We've looked at that. Lucas has put this draft bill together. I think, Mr. Chairman, if we could have Mr. Lubnow, and then I think we've got some online speakers there as well, and then we could look at that bill draft from Lucas. So
We do. Let's
Tom?
turn to Mr. Lubno first, sir.
Mr. Chairman and members of the committee, thank you for the opportunity to speak to you today on the subject of dementia directives. I'm here with Tarina Stidd, who's online from the American Academy of Estate Planning Attorneys. You know these statistics, but it makes me feel better to say them. According to the Population Reference Bureau, in 2020, 7 million Americans suffered from some type of dementia. Their estimate is that by 2030, 9 million Americans will have a dementia diagnosis. According to a study by Michael Hurd in the New England Journal of Medicine, the combined economic costs of dementia totaled an estimated $305 billion just in 2020 alone. They expect that to go up even further. You're all familiar with the toll on patients and families caused by this insidious diagnosis. Ms. Stidd offered a class earlier this year on dementia directives, which I attended online. I thought the concept was helpful and a good addition to our statutes. And so I sent an email to my legislative friends. My presence here today in a tie demonstrates that no good deed goes unpunished. I bring this bill to you. Wyoming has a very broad advanced directive statute. And as Representative Larson said, I just happen to be the prime sponsor of that statute back in the day. So it's the one I'm most familiar with. We have a whole series of statutes, and I don't know if you read my letter, that talk about advanced directives. We've got the living will statute. We've got the advanced psychiatric directive statute. We've got the PULSE statute, and then we've got the advanced healthcare directive statute. This one seemed like the easiest fix just by modifying a definition to broaden it. I think that these advanced directives are possible under existing legislation now with the language. But this definition or definition modification makes it very clear to families, to doctors, and to judges that the law allows people to make determinations as to their care during the progressive stages of the disease and allows it to change during the progressive stages of the disease. In my proposal, I proposed codifying the stages of the disease. I understand LSO's wisdom in not adding that to your bill draft and just modifying the definition to say that whatever stage the disease is, you can make a directive. The purpose of this bill is simply to provide to the people of Wyoming the ability to determine their own course of treatment. Ms. Stidd will discuss some United States Supreme Court cases which guarantee the rights of people to make their healthcare decisions. This bill simply proposes to expand the definition of advanced healthcare directive to include dementia directives. It's a pretty simple bill. Thank you for the opportunity to testify in front of you today, and I'd stand for any questions.
Thank you very much. And I think you remember, don't ever say a simple bill. Because don't ever say a simple bill because that will kill every bill. But anyway, that aside, questions for Mr. Lubnow. Go ahead, Director.
Thank you, Mr. Chairman. Speaker Lubnow, more of a devil's advocate question. Is there, being aware of some of the models nationally, is there a problem with our advanced care directive statutes being broad that was leading to confusion legally with whether they could be, whether dementia could be included in the current framework? Or is it more about just specifying dementia because it's a disease of the, brain degeneration, things like that? I'm curious for your perspective there.
Mr.
Mr.
Lubbock.
Chairman, Director Johansson, the latter. I think we can do this, but I think educating the public and the lawyers and in my real life, I represent doctors and hospitals, and I answer the questions from doctors about, well, what do we do now? And sometimes they're gut-wrenching questions. These are hugely gut-wrenching questions. If we can answer those questions in advance and let you all, or everybody in the state of Wyoming, when they're competent, determine the course of their treatment. And then the doctors will follow that. We've done everybody a service.
Further questions for Mr. Lubno? None. I don't see any hands raised online. Senator Barlow.
Thank you, Mr. Chairman. So just to clarify, I think in most of the other things, guardianship we just spoke about, it's either 1 or 0. We either have guardianship or we don't have guardianship. I think what's unique about this dementia one is there's gradations based on mental faculties, acuity, et cetera. And I think that in itself makes this one, at least in my view, and obviously Speaker Lubno could speak to this. That is why this one maybe needs to be spelled out more specifically, because it is a change over time, and people can actually maybe hopefully understand and forecast and make those decision points. And the court they don't have to keep continuing going back to a court to say, oh, now we need to change this. Now we need to change this. Actually, so I think this one is, at least that's how I'm trying to understand it, is this one's unique enough in this, the mental, that part, that I think this one does deserve this kind of nuanced attention. And I think the next is, don't you agree?
Would you like to comment to that, Mr. Lubno?
And Mr. Chairman, Senator Barlow, yes.
Quick and to the point. That's good. Further questions, committee? With that in mind, let's go online to Ms. Stidd. Still there? Go ahead and introduce yourself. Oh, couldn't hear you there.
There we go. Sorry about that. Hi,
you
everybody.
go.
My name
Go ahead and
is,
introduce yourself.
forgive me, Chairman. I apologize. My name is Tarina Stidd. I am the Director of Education at the American Academy of Estate Planning Attorneys. We are a national organization that helps attorneys all over the country kind of with all sorts of problems and issues. And this was brought to us earlier this year by a representative from the Alzheimer's organization because it is so important and so vital. And so I just want to echo what Tom has already said. He hit the nail on the head. And the big issue here is exactly that. This is an area where it is clear that you can make decisions while you're competent. We have these documents that say that when you are no longer competent, somebody else gets to make those decisions. But dementia is this period where you gradually lose competency over time. And one of the statistics I don't think that Mr. Lubna mentioned is that there's actually an 8-year period from mild to severe. And during that time, it's hard for an individual necessarily to be able to articulate what they want and how they want to be treated. So this dementia directive comes in and says, this is how I want to be treated at this stage, at this stage, and at this stage. The particular cases that I just want to speak very briefly about is Cruzan versus the director of Missouri Department of Health. In that case, the United States Supreme Court said without equivocation that a competent person has a constitutionally protected right to refuse life-saving hydration and nutrition. And so it's not just, this is the kind of care that I want, but when there comes a time in my life when I am only opening my mouth because it is a reflex, I don't want to have hydration or nutrition given to me. And so that might be a place where you're not yet ready to go, but I would suggest that that's a place maybe where you consider some additional legislation to come down exactly what's best for your constituents there. And then the other one is Glucksberg versus Washington. And once again, recognizing the right to refuse hydration and nutrition, just like you could refuse any other medical treatment whatsoever. That's what I got, unless anybody has questions for me.
That was good. Committee, questions from Ms. Stidd?
I do.
Oh, we got one for you, Mr. Co-Chair.
Thank you, Ms. Stidd, for joining us today and helping us to better understand this. It is very helpful. I just want to make sure are you suggesting, you've seen our bill draft, are you suggesting that we need some, there may be some additional language warranted in this draft, or did you feel that we had covered the bases that, as you research this issue, help
I
me
think,
understand, please?
absolutely. So I think that this is what has been proposed is really wonderful. We had suggested creating an actual dementia directive. And so I think that that's where Tom was headed with this, was that you all, it's already available under your statutes. Let's just make it clear that this is going to be a legally binding document. That's the problem. And so I think that to the extent that that document, whatever it is that's created, if you're going to accept them from across the country, because there are about 10 different places right now that have dementia directives, some of them do speak to that, this idea about not being able to voluntarily decline food and drink. And so that's really where the controversy occurs. And so if what you are going to use, if you're going to say any directive, anything that purports to be a dementia directive, regardless of the provisions of it, we're going to accept under these statutes, then that's fine. If that is something that's important to you, taking a stand on nutrition and hydration, then I would suggest you should include additional language that says including nutrition and hydration, including refusing nutrition and hydration. That can be included as part of the dementia directive. Does that answer your question, sir?
Yes, thank you.
You're welcome.
Further questions, committee? Director Schmidt.
Mr. Chairman, thank you, and Speaker Lovenow, thank you. I just have a question about the stages, and you had made a reference that maybe you given the LSO some information on what those stages are. And I'm curious, I don't know much about dementia as it relates to stages, but is there a body, a medical body of some sort that has determined what the stages are? So that that's not left up to some interpretation. As I think about those defining moments with somebody who's going through the course of that 8-year period, not having any argument about what stage somebody is potentially at.
Speaker Logan.
Mr. Chairman, Director Schmidt, dementia is a range of diseases, and the medical professionals in different journals have different definitions of what causes that, and some are biometric markers. What I tried to do in the proposed language was make it so simple that even a lawyer could understand it. And so I talked about symptoms. And so my proposed definitions were early stage or mild dementia is characterized by difficulty with short-term memory, concentrating, making sound decisions, judging time, sequencing steps to complete a task, or with visual perception. And then it says persons with early or mild stage dementia may retain the capacity to make their own decisions regarding their health care, but rely on a family member to assist these. The definitions were based on the symptoms. And then the late stage is characterized by inability to remember basic information, loss of ability to respond to the environment, to converse or control movement. Those symptoms, when they have those are unarguable. And so that's why I'd proposed the definitions. But I think that if you draft the dementia directive appropriately, which is what people like me ought to do with the guidance and people like Tarina, then we can do that without having these definitions cast in statute, because as you all know, disease progression and disease treatment changes over time, and these statutes will last a long, long time. So that's why I understand the wisdom. I did want to comment, if I could, Mr. Chairman, on something that Tarina said. If you look at the Advanced Healthcare Directive statute in the other definitions, nutrition and hydration is provided in there, so we don't need to add that. It would be redundant to add it to this statute. I had enough forethought to do something right a long time ago. That doesn't happen often.
Yeah, and I would add too, it's important we talk about hydration and nutrition as opposed to food and drink, because they are two different things. They mean something different. But go ahead, Mr. Woodger.
Thank you. Tom, in the bill, the staff makes a comment inquiring whether we should consider the term dementia directive should be defined in the chapter on living wills. That's part of the world that you do live in. Have you got any advice on that?
Speaker Lovell.
No, I just took the easiest way out. And in looking at all of the statutes, the easiest way out was just to change one definition in the Advanced Healthcare Directive. Essentially, I'm a lazy human being, and so if I can take the easiest way out in the most understandable way for a bill, I'm not going to give you a 40-page bill when I can give you a paragraph.
Very good.
Very good. Further questions? Any closing comments or final wisdom, Ms. Stidd?
Just one. If you go through with this, you will be the first state in the union to actually have a statute on the books addressing this. So you guys are way ahead of the curve here. So I hope that you do.
Wyoming likes to be ahead of the curve.
Well, call timeout. That's what we do.
Okay. Thank you very much, Mr. Lovell. With that, let's go ahead and, Lucas, can you go ahead and present the bill to us?
Absolutely, Mr. Chairman. Luke Plum, LSO, here to discuss 25 LSO-0216. This is Advanced Healthcare Directives, Dementia. I believe Mr. Lubnow in the discussion so far has covered it fairly well, but this one does amend Wyoming Statute 3522-402A1, and that's just in the definitions. And so what this specifically does is in the definition of Advanced Healthcare Directive, which means an individual instruction or a power of attorney for healthcare or both, it just kind of tacks on a definition or, further discussion for a dementia directive by stating that the term includes but is not limited to directives for dementia as follows. And it's dementia directives that provide individual instruction for healthcare decisions to address the gradual decline of a person who has been diagnosed with dementia. Dementia directives may include directions for healthcare decisions during each stage of dementia regarding the care to be rendered at each stage of the disease. So this was included in there. This was based off the language that Mr. Lubnow provided. I did make a staff comment in here that's already been briefly addressed, but just whether or not to pull out this discussion on the dementia directives into like its own definition instead of adding it onto the Advanced Healthcare Directive. Since that definition is just kind of short and sweet, you could pull it out, but it would likely just require conforming amendments throughout this article where it discusses Advanced Healthcare Directive. You probably just have to tack on and dementia directives. And so really that's just up to the task force decision. Once again, it was here, just including it as a since it's a subset of an Advanced Healthcare Directive. And just briefly to touch on the stages, that language was provided, that what are the early, the mid, and the late stages, just was kind of that thought about could that be overly limiting if you're trying to define the stages within statute, and not that statutes are necessarily a diagnostic tool. So it was just left to be this one single paragraph. But with that, I'd stand for any questions.
Questions for Lucas, committee? Seeing none, thank you very much. With that, committee, let's open up public comments. Any public comment online? Any public comment in the room? Any public comment from space? Bill has been moved. Public comments closed. Any second for the bill?
Second.
Second by Representative Larson, moved by Director Johansson. Committee, work through the bill, page 1. Page 2. I don't even need to look at the bill to do this. Page 3, question has been called. Roll call, please.
Mr. Chairman, this is a roll call vote for 25 LSO 216, Advanced Healthcare Directives, Dementia. Senator Barlow? Senator Nethercott?
I'm sorry.
Sorry.
Speaker Summers?
Aye.
Representative Zwanitzer?
Aye.
Director Johansson,
I,
Director Schmidt,
Aye.
Director Shannon,
Aye.
Mr. Brown,
Aye.
Co-Chairman Larson,
Aye.
Chairman Baldwin.
Aye.
Mr. Chairman, we have 9 ayes, 1 excused.
The co-chair and I will discuss that and pass that on to the next committee,
Next committee.
whoever that might be. Okay, committee, I think we're gonna take a quick break before we move on to our final topic. It'll be a quick break. It's not a 20-minute. How about 10 minutes? And we'll come back and hit our last pieces of agenda.
Albert, can you hear us? Albert, can you hear us?
Yes.
Oh, there you are.
Okay,
Okay, we just don't have a visual on you, so when we do any kind of a vote, well, you'll just have to speak up for us, but we're gonna go ahead and get started without the visual. Okay, committee. We are back to item 7, which is used to be item 8. It's item 7. It's our final agenda item of the day. And this is our K-12 mental health services. Yep.
Mr. Chairman.
Go ahead, Mr. Co-Chair.
So task force members, kind of the important component of this, we've had this conversation. What does it look like? We've kind of talked about adopting AWARE. Today, we're going to learn what AWARE, the fine lines of that, and supplementing in with BAR for the staff training. And the reason we're wanting this today is because the task force, the 2 chairmen need to be in front of the Joint Education Committee next week to say this is our recommendation as well. You recall they're a parallel track, and so we'd like to make this presentation and then get a feel for the task force on their support for this request or this recommendation to the Joint Education Committee. So that's the intent of this whole effort.
Very good. And before I forget, Senator Barlow wished to take a personal privilege moment here, if he would.
Thank you, Mr. Chairman. Before the day gets toward the end, I wanted to extend a thank you to the Youth Emergency Services and Ryan, their executive director, for the offer for a tour last night. I know a couple members were able to make it. I apologize, I wasn't able to make it, but it's really Youth Emergency Services provides crisis stabilization, all kinds of services for youth and families in Campbell County. It's really it's a remarkable facility and organization, and the people in it are just do so much in our community to strengthen families and our young people. So I just wanted to thank them for that and thank them for all their work here. And they've got a great team and we appreciate them. Thank you, Mr. Chairman.
Mr. Co-Chair.
And Eric, thank you, because I think it's so helpful to get in those facilities. I got there late. Ryan waited for me, and we went through tying all of these pieces between court-ordered and voluntary, the educationals, how districts and how all of that is very helpful. So Ryan, it really was time well spent for me, because as we have these important, particularly budgetary conversations and other conversations, that was provided components that were missing for me. So thank you.
And please accept my apology. I tried to get there. I was eating Maverick food, driving as fast as I could, and not wanting to go to jail. I went back to the speed limit and I didn't make it. So
Misdemeanor.
misdemeanor. And oh no,
Yeah.
that discussion's over. Okay. Now we got that taken care of. Let's move on to the K-12 discussion. We have bright smiley faces before us. You want to go ahead and kick us off and introduce yourselves?
Thank you, Mr. Chairman and co-chairman, members of the committee. It certainly is a pleasure to be here this afternoon. My name is Wanda Maloney. I'm with the Department of Education. And I just first of all want to let you know that our superintendent had planned to be here today, but due to a death in the family and the fact that she's attending the funeral today, she wasn't able to be here. But she certainly wanted you to know about her mission, her involvement in this work, and then also to be able to share some words with you in a few moments. With that, I'll turn it over to Dustin Brown, and he will go through some of the details of the information around BAR and AWARE.
Mr. Chairman, members of the task force, Dustin Brown, Wyoming Department of Education. Today, I wanted to walk everyone through kind of the nuts and bolts of what Wyoming Project AWARE is, so that there's no confusion when we're looking at potential motion or potential discussion in the future. With that attached, there is a 4-page memorandum that we're just going to kind of walk through and explain the large pieces of Wyoming Project AWARE. What I'd, oh,
Justin,
yes, sir.
And I believe that memorandum was sent out to the task force this morning. You probably have it on your email.
Yes.
Okay, thank you.
So the big rock, starting with Wyoming Project AWARE, what we've done with Wyoming Project AWARE is partner healthcare with education. We recognize educators are educators and healthcare providers are healthcare providers. So with that, we really believe in recognition and referral. And Project Aware is a referral mechanism. And so what we have is at the bottom of page 1, we talk about a community project manager. The community project manager is the linchpin of Project Aware at a school district level. This individual oversees mental health, substance use, initiatives for the school district. They make the connections between the school counselor who is working directly with the student, the teacher that's working directly with the student, and ultimately oversees that connection point from the school district to the behavioral health partner. What we've done in here is we've modeled our program off of the requirements that SAMHSA requires. So as we go through these personnel that are the key linchpins to Project Aware, you'll see, for example, bachelor's level education or higher with a background in education or healthcare preferred. What we're doing is we're mirroring those larger SAMHSA requirements as we've gone through and built our program. You know, a lot of the thought process being is we've shown success with Project Aware, so you know, no need to fix something that isn't broken. With that, the community project manager also administers the Project Aware mental health survey every other year. This is a comprehensive survey that we deliver again every other year that measures student life, it measures mental health, and it measures substance use. These are the 3 areas that we've been measuring for the last few years. And what we've seen consistently through this survey, where we've got multiple data points, is we see a more functional student population and we see a more socially connected student population through those surveys. And that's one of the ways that we measure success within Project Aware. When we get down to the paraprofessional that's identified in here, I want to kind of loop the paraprofessional and the behavioral health provider support contract on page 2 together, because these aren't actually, they are people that will work this work, but they're not actually positions. What we're looking at paying for here is a service agreement. This service agreement would serve us through a behavioral health partner that the district would identify and support our work. For example, in Carbon County School District 1, WBI provides the behavioral health partner support for the school district. So the paraprofessional is actually an on-site individual that serves in a paraprofessional CNA type role. They help support the student with wraparound services. They help get the student from the classroom to their telehealth session or to their live session with a provider in person, depending on how the program is set up. Yes, sir.
And so, and again, this isn't a district employee, it would be the service provider employee providing those coordinating services.
Mr. Chairman, Co-Chairman, that's accurate.
And in this document, you're just identifying, as we request funds, what you anticipate allocating, the cost allocation for those services that will be provided by the contract provider.
Yes, that's correct.
Thank you.
Very good. Go ahead.
Yeah. So when we look at the paraprofessional, they also collect what's called national outcome measures data. The national outcome measures data is the individual level data that provides support, and that's how we measure if the individual student is increasing their functioning and their social connectedness. These are the 2 key areas that we're identifying within Project Aware to measure. This data is de-identified. I can never tell at my level a student, like an actual named student, Johnny, is receiving services through Project Aware. It's an alphanumeric identifier that lets us see alphanumerically if that student is advancing through services. So very, very discrete from the Wyoming Department of Education's perspective. The behavioral health provider contract, what we've done is we've recognized that our services are somewhere between 60 and 80% sustainable based on billing, the coding and billing process as it exists when we have the provider working within the system. The 20,000 is there for each district in order to supplement that part that is not sustainable. With that, one contracted provider will see up to between 32 and 35 students at any given time. And it will allow throughput of about 120 to 150 students per year. So that is this is the package that each district would receive if Project Aware were funded at the state level. They would receive that community project manager at the district level, and then a service contract that would pay the paraprofessional and the behavioral health contract support provider. And then the last point is there's $100,000 in there for each district, which advances positive behavioral intervention systems and multi-tiered system of support. So the work for professional development and training, because a key feature of the AWARE program is continual advancement and continual knowledge gain for the staff, the personnel, because again, this is a referral mechanism, but on the front end, you have to have recognition in order to recognize the student need in order to refer.
So could, Mr. Chairman,
Go ahead.
so theoretically, you could take part of that and even use it for bar.
Yes, Mr. Chairman, Mr. Co-Chair, yes, that would be accurate. We could use, we could create a subset of that 100,000 and use it for bar, and then use the other portion for the remaining professional development and training.
Thank you.
Very good.
Now, when we look at what it would actually take to manage Project Aware at the state level, right now we've put in our proposal 2 education consultants at the ETEP 10 level. That would allow half the state to be managed by one individual and the other half of the state to be managed by another individual. We also have 1 consultant that we're requesting at the Department of Health. And that individual right now, we have a member of the Behavioral Health Division that has been instrumental in helping us connect with behavioral health providers. And that's kind of what we see the request for that individual to help support and provide support is helping us navigate those challenges with community mental health providers, providers in the different communities, and helping us navigate and circumvent barriers that would inhibit us from serving the population. Also, we have external evaluation support. This is so that we can measure the NOMS data in the surveys. The data collection is it's intensive from the perspective that there's a lot of data, especially when we extrapolate and look at 48 districts, all collecting 32 to 35 students at any given time, the data requirements. We've put an external contract in there to support that data collection, that data analysis. And then we have some smaller totals for travel, IT phones, and then a technical assistance contract to help us navigate any unforeseen challenges that we have along the way. Lastly, we have professional development training for the staff that would support on the state level side. So the 2 10s at the Department of Education and the 1 member of the Department of Health staff. And then lastly, something we've recognized with Wyoming Project Aware, we require all of our behavioral health partners to provide free care for 10% or more of the uninsured population. We have to have a way, a vehicle, a mechanism to reimburse that care to those providers. So there's an ask for $500,000 to create a pool where we could charge directly for uninsured and underinsured care for the providers, with the intention to keep the providers whole for that care that they're providing to the uninsured and underinsured population.
Mr. Co-Chair.
Dustin, would you say that all again? So there's a requirement for 10% of the un or underinsured. Start with that and make sure that I understood that correctly. And who are you requiring to do that?
So Mr. Chair, Mr. Co-Chair, with our current construct of Project Aware, we require our behavioral health partners to see 10% of.
So is that a Department of Health?
No,
or
so
your service providers, your contract service
Yes.
providers.
So
okay.
like going back to my Carbon One example, we require WBI to see 10% uninsured students.
Okay.
And so with that, we allow them to bill those services directly towards the grant, so that they're paid. And we allow them to bill the grant at Medicaid reimbursement rate for those services. We don't let them bill at actual cost expenditures.
So let's do an example for me, Kay.
Yes.
So student A, Lloyd's uninsured, goes to the WBI, has a contract. They, my services amount to $10,000, just for easy math. They would provide a 10% discount, then we would reimburse the 90%. Walk me through that part.
Okay, so let's say student A is receiving services at WBI. They are uninsured. Their bill is $200 for the cost of those services. Wyoming Medicaid rate reimburses at $125 in this example. That's not an actual reimbursement rate based off their fee schedule. But let's say the Medicaid fee schedule reimburses at $125. WBI would bill directly to the grant $125, and we would reimburse that to WBI for seeing that student that was uninsured.
And so I'm trying to tie in this 10%. I'm just, and I'm sure it's plain to everybody else, but I'm missing it.
No,
So,
not at all.
so what's this? You said that they are required to see. There's a 10% number. You use the term
Yes.
10%. Who is that? What is that?
The Mr. Chairman, Mr. Co-Chair, the 10% is the population of students that are uninsured or underinsured.
So you have 100 students, 10% of that's 10 students that are uninsured for this, that they would still be required to see.
So I'm gonna actually make the soup muddier.
Okay.
So we have 100 students. 4 of those students would be seen under the program because we recognize through the referral mechanism, ultimately we'll see about 4% of students. 10% of that 4% of students are likely to be uninsured or underinsured.
Okay.
So if we have 100 students in the program, because we've got 400 students in the school, then, or my apologies, if we have, sorry, my math is not mathing this afternoon. Let's say we have 100 students in the program. 10 of those we would anticipate being uninsured or underinsured.
Right.
Now that will fluctuate based on community when there's a higher.
Yeah, just use the
Yes.
10 though.
So when we have those 10 that are uninsured and underinsured, WBI would see those students at no cost, and they would bill the grant directly for that care at the Medicaid reimbursement
But
rate.
that is a cost. So they didn't see no cost.
No cost to the student or the student's family.
Okay. So they wouldn't direct bill them. And I'm tracking with you there.
Yes, it would
Thank you.
bill directly to the grant because a large purpose of Project Aware has been to minimize the barrier of cost
Okay.
within the construct.
Thank you.
You're
Mr.
welcome.
Chairman.
Mr. Director.
Very briefly, Dustin.
Yes.
So I know that you all are dealing in kind of estimates based on our statewide uninsured rate, but for the 10% you're thinking might need to be targeted, what does underinsured mean? Is it any cost sharing that a private health plan has? And then on the uninsured side, why do we anticipate the student or the child would be uninsured? Is it because of the family doesn't want to take advantage of, Medicaid or CHIP or private insurance on the marketplace? What's the kind of assumptions behind that?
Yeah. So, Mr. Chairman, Director, on the uninsured, underinsured perspective, what we have is that paraprofessional is there for wraparound, trying to get the student and the family enrolled in Medicaid and other opportunities that are out there. But the assumption is we've got that gap where they're not qualified for Medicaid, but they're functionally unable to have insurance. And that's that population that we're kind of trying to estimate within our cost example. It's not an exact science. We've kind of done the numbers to the best of our capabilities on capturing where that gap exists. Now, on the underinsured, we've declared underinsured as anything that would consist of $1,500 out of pocket per year for the family. We've just used that traditionally throughout the Wyoming Project Aware program since 2020. And I would maintain that unless there was another effort. I'd be completely open to another effort to redefine that.
Yeah, Mr. Chairman, if I may, on that note, again, just going forward for planning purposes, so Medicaid covers children up to 138% of the poverty level. Then the Medicaid CHIP program covers children with family incomes up to 200% of the poverty level. So for your total, for your uninsured, you'd be talking about families over 200% of the poverty level, which then to me renders the need more for navigation to healthcare coverage resources, which you just addressed. I mean, having someone trying to help folks sign up for that, it's on the adult side, absolutely. There's a gap there, and you don't qualify for subsidies for marketplace insurance. You also don't qualify for Medicaid. Generally, that gap for adults is between 50% of the poverty level and 100% of the poverty level. But for kids, it's much higher. You know, basically we have public insurance for children up to 200% of the poverty level. So just to make sure going forward, we are providing you the data, because from a census perspective or health insurance perspective, we can get more precise for you on that if it would be helpful.
Yeah, Mr. Chair, Director, that'd be very great for us. Thank you.
Senator Barlow.
Thank you, Mr. Chairman. So I'm not going to do a numbers exercise, but there's 90 plus thousand people or students in our K-12 system, 93 or 4. I mean, we're in the beginning of the school year. There's 60 plus thousand on Medicaid or, okay, maybe, no, children. So maybe, 35,000. So I'm just doing the numbers, a third. So what I guess my question is Project Aware a first payer or last payer? Thank you.
Go ahead,
Mr. Chair, Senator Barlow, we've designed Project Aware to be a last payer.
I'm intrigued by the algebra problems here, but.
This is no algebra, land or math.
Okay, go ahead, Dustin.
Yeah, Mr. Chairman, so the last item we have is when we scale Project Aware and we look at the total cost of the program for Project Aware, we run into $13,469,200. So it's an approximately $13.5 million investment for Wyoming Project Aware on a rolling annual basis. And it'll allow us to see approximately 6,000 students a year based on the rough math.
Go ahead, Mr. Co-Chair.
So Dustin, we're taking this out of a pilot project and kind of implementing it into policy. And so I think coming back to the uninsured thing, maybe we've got time, but I think that it warrants a discussion because I think for the population being served, there shouldn't be a gap. There should be provisions through Medicaid and CHIPS that we shouldn't have to anticipate nobody, not being able to compensate the provider for those services unless you've identified that a parent doesn't want them to be enrolled or, there's some anomaly. So could you, we don't need that today, but that might be adjust our numbers there a little bit if we can verify that if I'm getting a couple of shakes of heads that maybe we can get together and verify that because that might adjust that end request. Is that fair? Okay, thank you.
Thank you. And that would be great if we could have it before Wednesday.
Yeah, we can, even at Wednesday, we can say that this is, that we're working on this. We've identified some further questions.
Very good.
Thank you.
Okay.
So in addition to the Aware costs, we've also constructed the BAR costs as a standalone program for further discussion. The BAR annual costs through and This is information that Lachelle and Barr directly presented when we met in Torrington. We would need 287 contracts at 80,000 a year at a total cost of 22,960,000 to fully fund Barr within the state. That would be per year for 3 years. Now, Barr in and of itself is a program that is not intended to have a tail. Their construct is come in for those 3 years and then leave after that. Also with us is Angela. Angela with Barr is here in case there's more specific questions on Barr, but this is kind of where we are from a mathematic perspective.
Go ahead, Mr. Co-Chair.
Keep kicking Director Johansson. I apologize. Well, kind of. So I think the conversation we've kind of kicked around as a sidebar since we had our meeting at Torrington is, do we want to go in for this initial 3-year, $60 million request for Barr, plus an additional 13 million request for Aware? I think that the appetite in a supplemental budget for that is going to be extremely difficult. And so I think we have a fuller understanding of Aware and those costs. Barr's costs, I think we've come to conclude that we could perhaps maybe we could phase that in and get some data to validate that that the program is working as we believe it will or is intended. So some of the ways we could do that, as we mentioned earlier, is maybe taking part of that administrative cost. We also had in footnote 321, maybe, I can't remember, we allocated $10 million for mental health grants back to the districts. We could contemplate maybe changing the language on there to also allow that to be used for Barr funding. Looked at that, it gives some ideas on what that funding is available to be used for, and we could amend that to do that. So to task force members, I think that we have the ability to phase in Barr, and as we start to see, as we anticipate that the results are positive, that I believe enables us to then move forward with additional requests that we can provide data for that says this is working. And the other component of that is as we implement Barr, and I think that the districts want to participate in Barr. And so I think that there would need to be some discussion in the department on how that would work. I think it's some of the conversations that we've had and who would be first in line to participate in that base. But I think that that's certainly something that's left at the agency's table. But I think that I don't think we need to go to the legislature in a supplemental budget year and try to squeeze out $68 million for the total funding of Barr. I think it is important to note, though, that when we commit a school to Barr, that we need to have enough there to fund the full 3 years. So 80, 80, and 80 is one. Does that sound right? That it's about that. And so those are just some thoughts, Mr. Chairman, that I've had as we look at this, this all in clean approach. So Dustin, if you'd like to make any comments on that, or if I've misstated, please feel free to say so as well.
Yeah, Mr. Chairman, Mr. Co-Chair, WDE is right in line with that thought process. The $68 million is a very large ask. We think scaling it and getting data would help us better understand the investment that we're putting into BAR. So utilizing that 100,000 that's in Project Aware makes a lot of sense operationally.
Very good. Go ahead, Director.
Thank you, Mr. Chairman, and thank you for the presentation. And you may have said this, but I missed it. Have any school districts expressed any interest in BAR? I mean, I know we've been having the conversation here and the consultants came, but was there a larger conversation through the school districts about that model that didn't necessarily take place here?
Yes, so Mr. Chairman, Director Schmidt, through, with BAR, we've got a pilot that is with 3 districts right now for 6 schools. And we've got interest in BAR by and large. Timing is, we have to have enough timing on the front end to get BAR up and running with the start of the school year. So timing is really crucial with BAR because there's 2 days of training attached to BAR. And so planning it in, but yes, we've got plenty of interest in BAR.
Thank you. I was getting my programs confused. I do remember that from one of the earlier meetings.
Yes.
Thank you.
You're welcome.
Any further questions? See none.
All right, the other item we have, I'm going to turn the floor over to Ms. Maloney, is the superintendent's framework. So thank you for your time, everyone.
Ms. Maloney.
Thank you, Mr. Chair, Mr. Co-Chair, members of the committee. I just wanted to walk through the superintendent's vision for mental health in the state of Wyoming. She really has 3 purposes that she's outlined. The first one really is the fact that the belief in this work that we're doing is so important. The number one, the increasing suicide rates in our Wyoming, which continue to far outweigh the national average, are really unacceptable. Tragically, you're aware, Wyoming has the highest suicide rate with 32.3 per 100,000. And the country across the nation has the rate of 14.1 per 100,000. Secondly, in terms of purposes, behavioral issues have continued to escalate in our schools, and they also continue to be one of the top concerns for our teachers on whether they plan to stay in their career field. The department has asked for a survey, and we have received information from teachers, and it ranked number 3 in terms of their concern about the behavioral issues that they're dealing with. Number 3, over the last several years, there's been a breakdown of trust from parents in public schools. The absolute number 1 that the superintendent has heard on the campaign trail was regarding political influence on children's education. We must rethink how we are responding to the needs of students while at school. Our current approaches need to be changed because not only have we seen suicide rates increase, but the trust from parents has decreased. So where do we go from here? What are the next steps that we can do to partner not only with families, but address the students and the mental health needs? As the superintendent looked at this, she really garnered 3 principles. And the first is around parental rights. When she looked at that, first and foremost, we must honor and protect the rights of parents. Everything we do must not only comply with the recently passed statute 21-3-135, but actively inform parents every step of the way to rebuild trust. Secondly, many of you know that our superintendent comes from a private sector with an economics background. She believes that we have to stop expecting our schools and our teachers to do everything for everyone, and teachers to continue to be expected to do everything, including beyond their expertise. Teachers are not equipped to handle the issues of mental health interventions, and the ones that the superintendent has talked to, that she's spoken with, don't want to have to address. Again, schools need to be getting back to the basics, and we need to think about how we can shift the system to create efficiencies and also recognize specialization, which really leads into number 3 in terms of principles. that intervention is the best referred out of the schools to the appropriate community channels and ensuring that we're communicating with our parents along the way. So as we look at the framework that the superintendent envisions, it really has three components. The three are prevention, identification, and referral. When we look at prevention, we're really looking at some of the things that are happening already in schools in terms of student-centered learning around competency-based learning, project-based learning, problem-based learning, along with career and technical education opportunities for our students, really are a tool that can support students with mental health issues. If we move away from the factory assembly line approach and provide students with career pathways that they feel passionate about, they will thrive. Second, in creating a system within the school that is different than how we've envisioned school, it really looks at providing multi-tiered systems of support and also looking at finding ways that we can find the passions for students. This means that we have transparent teams of teachers that are working together and are regularly discussing the strengths of students, further advising them and supporting them in things that are of interest to them. And then also looking for any red flags that they might see as they work with students, and looking for ways to refer that out to get the best specialized support for those children. Next is identification, which involves immediate communication with the family and the parent and working with our community systems. Lastly is referral, and this is where the intervention takes place, really working to ensure that we have the best source of expertise working with our students. And if you could see the framework, I know we're not projecting it, but one of the things that we've done in thinking about prevention, identification, and referral is looking at those programs that are currently in our schools and our potential programs that we'd like to move forward. So the first one, when we think about prevention, which we've talked a little bit already, is around student-centered learning. So student-centered learning looks like engaging students not only with content, but giving them the opportunity to go out, to work with the community, to actually do internships and apply what they've learned in the ground. The second one, and Dustin, I'll have you join me as we continue to walk through that, is around BAR. And we're talking about BAR being preventative, but also supporting with intervention, or excuse me, with identification. So BAR is really teacher teams looking at the strengths of students and identifying and supporting those students in ways that can further that. And then also looking for ways when they do find that a child is struggling, that they're referring that out to the community to get additional support. The last two, which I'll hand over to Dustin to talk about, which are aligned programs, which cover some of the other components, are AWARE and care coordination.
Yeah, thank you, Wanda. So with AWARE and with care coordination, we have identification and referral within AWARE. That's the pillars that AWARE has been built off of, is identifying student need. And we do that through training and education for the staff, the school district employees, teachers, trusted adults. And so we have that identification factor. Then we have the referral factor to the external partners that work with us. Again, going back to what I said earlier with, we want educators to be educators and we want healthcare providers to be healthcare providers. We don't want to turn the education system into a healthcare model. We just recognize that's not foundational to where we are. And with care coordination, this is completely referral, a referral source. So care coordination takes all of the steps involved with going from needing an appointment to actually getting that appointment. So calling and finding the right provider fit based on the family's needs. steps as far as scheduling what day and time is most appropriate, working with parents, understanding working hours, that parent may only be available at 7 o'clock in the evening after working for the day. Care coordination takes care of all of that. And we have a very robust care coordination contract here in Wyoming through our partner Care Solace. And that contract allows all students and then anybody attached to the school district, the school system in any way, shape, or form. It actually covers about 90% of the Wyoming population. It's not just there for our student population, it's also there for our families, it's also there for our teachers, our administrators, district staff. All those parties can utilize this care coordination service as referral. And we recognize it as one of our benchmarks of our framework.
Very good. Before I forget, because I will, Wanda, can you pass on to the superintendent, please? Please convey the condolences and the prayers from this task force.
Chairman, I certainly will. Thank you.
Thank you very much. And thank you very much to both of you for your presentations today. Questions? Go ahead, Director.
Thank you, Mr. Chairman. For Wanda or Dustin, Superintendent Degenfelder and I actually come from similar backgrounds in the dismal science of economics. So I agree with the statement you read on her behalf of, knee jerk sometimes in policy is we perceive a mental health issue, in this case in K through 12. Let's layer in mental health services into the K through 12 system. And I think it's dangerous because you risk, turning K through 12 systems into healthcare or mental health care spaces, and it's not always appropriate. It's been kind of the theme of this discussion the past 2 years with this task force. I'm curious specifically, though, we've talked a lot about Project Aware over the last year and more recently with the BAR model. I'm curious about overlap and potential duplication. So what I recall from the BAR presentation from the folks that joined us in Torrington was that part of that training, part of that programming is to build up the ability to refer out, especially at higher acuity levels where there really isn't expertise. And then I see Project Aware, which builds similar functionality. So is there overlap, duplication? If a district wanted to go all in, either with their own allocation or with state support from dollars and went full, BAR model, does that render Project Aware unnecessary? Or do you see these just being additive with, investment in BAR and investment in Project Aware, or is there duplication there?
Right. Mr. Chair, Director Johansson, I think they're complementary in nature. What's occurring right now within Project Aware is we're utilizing various different sources to help us support the identification of needs. So, for example, we utilize Hope Squads in some school districts that are with Project Aware, which is a student-based program. We utilize youth mental health first aid to identify student need. We utilize Jason Flat Act trainings and things like that. And that's why I say they're complementary to each other. BAR can provide that recognition and referral piece, and there isn't going to be necessarily duplication of effort, but the way BAR and Aware both refer, there's potentially overlap there, but actually threading out and determining if BAR was how they recognized it or this other recognition mechanism, I think we'd have a really hard time kind of parsing out at that level.
Mr. Chairman, quick follow-up. No, and that makes sense. I guess just from a very high level and full disclosure, not an educator, don't live in your world, so take it with a grain of salt. But recently we have seen in the districts and from education systems that implementing programs to try to help, to try to give schools resources or curricular systems or processes that can help with mental health needs in schools, and totally get that and understand that. My concern is if we're layering too many different and disparate programs into the education system, where I just assume District X, hypothetically, we have done Project Aware, another program, now we want to go to BAR, and all of those programs are operating simultaneously in a district. without could muddy the water of kind of the strategic vision of what mental health in that district or that school means. I don't know if any of that makes sense, but we see it in our world in healthcare all the time where the next thing is implemented with, a project to change the way that health management or care coordination or what have you happens. And then suddenly we have, healthcare providers, hospital systems, what have you. And we go, my goodness, we have half a dozen programs all trying to do the same thing here. So your thoughts on that would be greatly appreciated.
Mr. Chairman, Director Johansson, I think we do have that overarching concern. And I would say that's not solely I think that's a recognition that within the state through multiple bodies, there's this recognition that we have to do something. And so we funneled so many resources as a state to combat youth suicide, for example, or youth mental health needs. I think the jury's still out on which one is absolutely the right way. This framework that Wanda has outlined is where the superintendent envisions us to go for our K-12 system. Not that you have an outstanding point that we don't want to override or overwrite the work where a district is already being successful. So our vision and our attention, whether we're talking Project Aware, we're talking BAR, we're talking the framework, is not to supersede control of local initiatives that are already working. We want to supplement and be complementary to those initiatives that are working. And I would suggest that in our last presentation, BAR talked and used the analogy. BAR is the glass, and all the initiatives that you're doing are the cubes of ice or the furniture in the room, as another analogy. BAR is kind of that piece that wraps around everything, more so than kind of pushes everything out of the room, and now you've got a blank, compartmentalized room. So yeah, I absolutely understand your point and your perspective. And what we're really focused on is not taking the good things that are already out there, but having something that we say, hey, this is what we support, and we need to get some data on, seeing if this is the right direction for Wyoming and K-12.
Mr. Chairman. Mr. Chairman.
Who said that?
Angela raised her hand, and if it's okay for
Not
her
yet,
to
not yet.
provide some comments, okay.
Thank you. Go ahead.
So Dustin, if I may, I'm just trying to get some math done here that doesn't quite make sense to me. The paraprofessional is 35,000 per district. That's going out to the contractor. That would come out to about 1.6 if you times the 48 districts. But the behavioral health provider contract is only 20,000.
Yes.
So it's less.
Yes, sir. Mr. Chairman, Mr. Co-Chair, the reason why is we want coding and billing infrastructure and processes that occur within the behavioral health partner already. We want, that's the sustainable aspect of Project Aware, is having that caseload. So we recognize, with the support of our current behavioral health partners, we recognize that Aware is currently 60 to 80% sustainable, depending on the model, whether it's an in-person model versus a telehealth model. And so that $20,000 actually supplements that provider's salary that they're having work on the program, recognizing that, for example, during the December recess, there's throughput that we can't match because the school system closes down. So we need something to kind of supplement and backfill that lack of throughput that we have at that time.
Okay.
Okay. Somebody wrote that hand up. Director Schmidt.
Mr. Chairman, thank you. As I try to think about the operationalization of the model, the MTSS, the multi-tiered support systems, and then kind of the superintendent's vision. As you think about those places of what's academic and what's not academic, are there some some of the, does that correlate with one of the tiers as kind of the signal to the schools to say, this is what we mean about academic and non-academic? And the real question is that certainly we know that sometimes behavioral issues get confused with mental health issues. And what is it that is going to help schools maybe be able to tease out really what is the difference? As this referral system starts and there's, you know, this encouragement to specialized, what then do you expect communities to pick up that you think the schools maybe are now?
Wanda, go ahead.
Certainly. Thank you, Mr. Chairman, Director. I'll just take the first part around MTSS. And if you think about it as a framework as well, it's a system that really has tiers, and that first tier being, you know, all students having access. And some of these models, when I think about competency-based education, really is tier one. That's looking at all students to engage them to be active and love school and want to be there every day. I also think that BAR has the ability to help teachers really connect with those students and look at the strengths that they bring every day. And that's all students. So looking for those red flags. So again, that's tier one. Tier two then would be looking for identification. Are there ways to identify kids that are struggling on the behavioral side or on the academic side? If it's academic, again, they're going to look for things that they put in place, whether it's small groups, whether it's a different resource, whether it's after school, it could be, you know, someone like a mentor that connects with them. Again, I think, you know, looking at some of the tier two for, and I would have to have BAR speak to how that could look for, and then tier three is really those specialized concerns. If you need to refer out because you don't have the expertise in the school and you need to find somebody in the community, then that can work to provide the best resource for that child. And I think you're right. I think really being clear about definitions, looking how both of the programs could complement each other. When you ask the question also, Director, about the difference between them, you know, thinking about the Project Aware is really being something that works to identify and refer. BAR being something that really is preventative, looking to really support those all students at that tier one.
And
Mr.
Mr. Co-Chair,
Oh, go ahead, sir.
the second part of Director Smith's question about behavioral versus mental health items. In our 14 aware districts that we currently have right now, we have existing processes in place, which we would anticipate broadening if we were to launch Project Aware across the state, to recognize that the communication between the school district and the provider is truly there to support mental health need, not behavioral need. And the schools have been very adamant that behavioral needs are within the purview of the school district. So we do have existing processes that have worked very well. So I would articulate that as long as we replicate those processes, we shouldn't have any problems there.
Mr. Co-Chair.
Thank you, Dustin. I thought we had MTSS and PBIS already in the districts.
Mr. Chair, Mr. Co-Chair, we do. It's varying at different levels and different success rates depending on the specific districts. But it's MTSS and PBIS are kind of always moving forward and always advancing based on new knowledge and new experiences within the classroom, turnover, things like that.
How are they funded now?
Ms. Maloney.
Mr. Chairman, Co-Chairman, they use their own district funds to be able to support that, to provide training. And then the state provides free training that we offer for districts to engage.
And I get that. So if it's already funded internally, why would we add funding in to do that?
Mr. Chair, Mr. Co-Chair, we've added that to allow them to be more robust in that training by providing it and articulating it as part of the budget for Project Aware. I think it's been a cornerstone for why we're seeing functional data increases and social connectedness data increases. Because we're giving them more where, for example, they may not have to utilize they may not have to utilize a course that is, they can utilize a course that's easily and readily available, but then they can also get specialized training with those additional funds. And that's what we've done through Project Aware. So that's what we replicated within the state level modeling.
And follow up, Mr. Chairman.
Go ahead, sir.
So that enhanced training, I would assume would be one-time funding.
Mr. Chair, Mr. Co-Chair, it's hard to articulate it as one-time funding unless you utilize a train the trainer type model, or you utilize a something that increases sustainability and capability. I think it could potentially be a mix of both. There could be a little bit of a continuous need, but I think to your point, I think the vast majority could be done through a train the trainer type model where it'd be one time and then it would be sustainable, similar to kind of the BAR process.
And Mr. Chairman, what I'm trying to get to is I'm just trying to think of any way we can to whittle down the 12 million. And if schools are already paying for that, why would we pay for it again? I'm hearing you say, well, but we could enhance and do it better. And I appreciate that. But that's telling me that it's 100,000 per district per year that we need. It's ongoing. It's that, we've not identified why it makes it better as much as it puts more resources there that could allow it to be better. But I'm not getting a clear definition of what that's going to do. Am I missing?
No, Mr. Chair, Mr. Co-Chair, I think that's a fair and valid point.
Okay.
Mr. Chairman.
Further questions, Senator Barlow.
Thank you, Mr. Chairman. So just two comments. I think there ought to be a limit on how many acronyms you use in any discussion. Because I've come up with several acronyms of the acronyms now, but I won't share them. But I guess more specific to how this applies on the ground, and this I'm going to use Campbell County School District number 1. We have, as you probably know, one of the school-based clinic type model, or I don't know if it's a model, but we have that in our community. And so when we start talking about referral out and all these things, I start saying, well, so is this trying to replace or change something? Or I guess my question is what of these things is optional, opt-in? I mean, what of these things is opt-in as, I don't know, not best management practices, but opt-in versus what can a school district do with their block grant funds to accommodate what they think works in their community. What happens to be in Campbell County at this point happens to be a memorandum of understanding between our hospital and our school district to provide many of the, I'm not saying the services, not the trainings and some of that, but the services that would be referred out, which is what it's talking about. So anyway, you don't have to address the acronym. I know those are not all your acronyms. You're using someone else's acronym, but I am curious about what is opt-in out of GRIT, BAR, down the line. What is opt-in for the districts versus, and then are we still going to allow them enough latitude to do the things that maybe work for them? Thank you, Mr. Chairman.
Good, Dustin.
Yeah, Mr. Chairman, Senator Barlow, I think we look at everything from the perspective and just to plug the community project manager, Michelle here in Campbell County School District 1 is phenomenal at running the AWARE program. I think we look at everything from the perspective that we don't want to override local decision-making processes and force anything on anyone. We want everything to kind of be an opt-in process from when we're looking at AWARE, we're looking at BAR. We've got a lot of school and district level support for these programs, and I think I think there's a factor to it. When you build it, they will come. And I think that's what we're kind of looking at, because we get those requests continuously. When's the next AWARE program coming out and how do we participate in it? So I never envisioned, and I don't think the department has envisioned, where we would force Project AWARE on any specific district. We would treat it more as an opt-in, and then build on success through that opt-in process, kind of in a similar manner to how we launched Canvas as the statewide LMS, building off the success and word of mouth that it's gone to where we've naturally, through integration, planning, and management, that we've been able to capture nearly all districts with the program. And Wanda, if I misspoke, please.
That's correct.
Senator Barlow.
Thank you, Mr. Chairman. So I certainly appreciate the build it and they will come, but I think the fund it and they will come is also to be considered here. So I guess if it has high level of value, and we're going to have this discussion, recalibration comes up here pretty quick. We're going to have this, and we're going to have inside and outside the block grant type discussions, just like the $15 million was noted earlier that, went for mental health grants or whatever. I don't remember the topic, but anyway, so I think that, I'm certainly supportive of giving, providing avenues to resources at school districts, but they got to have a commitment to take it up. Sometimes, not just because it comes with funding, because they think it's going to be meaningful. So I guess that's my, I don't want to push the economics on them. I want them to want the want to believe in it and be willing to, I don't know if it's a cost share type thing or something that makes sense. Is you believe in it? Okay, we'll come alongside you outside the grant or inside after reading. Anyway, I appreciate what's trying to be had here. I just want it to actually get to a place where it's being deployed meaningfully by the folks that are deploying it. You're providing the basics or the oversight and the overview and everything. But it's got to be, if it's not deployed on the ground, it's not going to be effective, obviously. So thank you, Mr. Chairman.
He said yes, he thinks yes. Okay, committee, further questions? And online?
Mr. Chairman?
Go ahead, Senator Barlow.
Thank you, Mr. Chairman. So I'm understanding from your co-chairman, Mr. Chairman, that this is going to be presented next week in front of education. So just, I know you're going online and take other comments. What would you like out of this committee as a recommendation, et cetera, or what would the Department of Education like and the superintendent like? Because I would assume the superintendent or Department of Education would be going to be part of this process next week in front of the Education Committee. So I just need some clarity about what they think we would like, or the superintendent think she would like, and this committee, how we can assist. Please. Thank you, Mr. Chairman.
So the request from the department, from the chairman of the Joint Education Committee, was to attend their meeting and provide some comment on what we've learned, what we've learned through our interim study on providing some sort of mental health services in the K-12 model, and how we would accomplish that, and then to make a recommendation, if any, on what that would be. I think, in full respect, I think that coming out of the meeting that we had in Torrington, I had in my mind that the AWARE would be implemented, and we would support BAR being also filling a gap in there and training the districts. I still think that has value, but I think on the funding side, I want to look at this perhaps a little more, and would like to have some time with the department on coming back now that we see how the costs are broken down on Aware to reevaluate, and I will give you a couple of examples that we have on page 4 of the document that Dustin provided for us. We've got well, let me go back if I may. We have total cost for the districts for just the project Aware is 12.4, and then there's some additional annual state costs that would be 1.2. But if we can look at this and have some further conversations, maybe 500 of that 1.2 million is the underinsured, uninsured component, which I think needs to be looked at. There's a Department of Health consultant that's 105,000, which the director says they could probably do without. Want to get a little more idea, I think travel, phones, and if we go with the two Department of Education's positions, then there's a need for phones and travel. We see that all the time. There's professional development and training and technical assistance, and I want to tie that back into this PBIS and MTSS stuff, maybe that, and I just need to get my head around that a little bit more. And so I think the concept of being able, and I think the superintendent, I agree with the superintendent, and I think her vision of how we provide these mental health services in the K-12 model align with what we've talked about in screening, intervening, and referring. And so I think now that we have that is to, we've got time. We'll meet and share some of these conversations, but I don't know that I'm ready to come back and say that it's this full amount, and but have some of the conversations that maybe these are some areas that we can look at based off what they've said. They're going to draft a bill and make a recommendation, and then we've got time to continue to work that. So I think that would be, Mr. Chairman, unless you're seeing that differently. This has been very helpful today, Justin, just enormously helpful to get a little better idea of how we're implementing that. I wished, and I will take the blame that I didn't request some of this more detailed stuff earlier, but it helps us prepare. And then I think between now and Tuesday, maybe we can have some further conversations, get my head around. I would share with the task force that in the conversations that Ms. Maloney and the superintendent and I have been in, the superintendent is very cautious about making unnecessary funding requests. She's been very, very, very vocal about that. And so I think, just looking at this information that's broke down, we'll go back and look at that. So I don't know that we really need to take a motion as much today as I'll just kind of report back on what I think we've learned. Unless there's any of the members that feel contrary to that.
I think you stated that well, and I don't think we need a motion. Go ahead, Senator Barlow.
Thank you, Mr. Chairman. I do think, Mr. Chairman, to the point of the presentation that Chairman Larson and certainly Department of Education will be a part of next week, I do think having a graphic of some sort or something, and I'm sorry, I didn't look at the document this morning, that says, this is how these fit together. This is the building blocks, and this is what we're trying to accomplish. This is the existing funding. This is something that would sustain the program or extend the program. I think that will help we've been listening to this for several meetings. You're going to go to a committee that is going to hear it for their first time. And I think maybe something visual would help me even now after we've heard it. kind of put those pieces together and understand, okay, well, this is our goal, but these things really help facilitate that. And these are the different investments that would be necessary, et cetera. I think that would be just a respectful suggestion that as you're working through what you want to think we learned, let's make sure we can actually demonstrate it or help them understand what we've learned. And that, to me, that's something visual that's does not have, has a lot of really nicely placed acronyms and colors and colors. Thank you, Mr. Chairman.
Go ahead, Mr. Co-Chair.
And this coming from a former chairman of Labor and Health, where all acronyms originate, so. So what I'd like to do, and maybe Wanda, we talk, but I think we need to take this document that you guys provided for us, restructure that just a little bit to take some of the confusion out of it that you and I talked about earlier, revisit some of these numbers. But I believe, because I agree with that, but I also believe that when we were in Kimmer, the Education Committee received a lot of this presentation. They've had a full conversation on bar, and they've talked about. So this is, I think the effort here is try Management Council give this task force and the joint education the same assignment. And I think we're just trying to reconcile and make sure that we're on the same page. I think they're interested in knowing what we've learned in any suggestions that we might have.
And I think it's worthwhile to put together, reformat this as you're talking about. And that solidifies our position a little bit when we go to education, that we give them something more visual to look at.
Mr. Chairman.
Director.
And just a little bit of a reminder as we kind of think about how this works. And, you know, a lot of our conversations started around those very high need kids. That those at any given time, those 20 youth where we are just struggling to find appropriate behavioral, mental health, educational placements for them. And I think the tie back to this about somewhere, somehow, if we can get a foothold and have some systems that are in place, that so we can either decrease the number of kids that get to that severity or at least postpone some of that severity as a systems approach. I mean, this is highly educational and it's very much seeped in the educational world, but coming from human services, these types of programming are so important to us as we think about the severity of the problems as they continue unaddressed through the rest of, you know, that student's life and the family's life. So just to kind of a tie back to our roots with this conversation, really talking about those high needs kids.
Go ahead, Mr. Chair.
Thank you, Director Schmidt, for that. But I think also what we've learned so interestingly enough, my county has just had some, over the latter end of the school year and in the summer, we've just had some significant loss of teenage life. In behavioral challenges were not ever evident. You know, these are kids that are in the top 10% of their class, maybe, or can really bounce a ball good, run far. It's not always that they have a behavioral issue, but there's some, and I'm kind of learning that behavioral and mental health can sometimes be a different animal. And so the schools are strapped. They've got special ed and IEPs and they're dealing with behavioral challenges, but then we've got this mental wellness when you're valedictorian all of a sudden has an eating disorder and wants to. So I think we're trying to get our head around all of that. So we'll do our best to move this forward because we know it's needed and we know that we've got to get something in place.
Okay, very good. Thank you very much for coming.
Thank you.
Okay, committee. Let's turn to LSO now because they've been very quiet. Oh, public comment on that one. Okay. And if we could see him, it would be better, but we'll just take a voice if you want to let him in.
Angela, you can go ahead and offer any comments if you'd like to provide any to the task force.
Well, I appreciate that. Actually, Mr. Chairman,
We cannot hear you. I just need one moment. Okay, Angela, can you go ahead and
hello,
speak now and see if we can hear you?
can you hear me, Clarissa?
Yes. Yes, we can. Thank you.
Wonderful. Well, actually,
Go ahead and introduce yourself, Angela.
good evening or good afternoon. I'm Angela Cherebeck, and I just want to, Mr. Chairman and Co-Chairman, thank you for your attention to this. And I actually wanted to make a comment about the closing comment about the number of students who are struggling, that in the past, maybe they indicated in other ways, and also the toll that that's taking on our educators in terms of them seeing these students and how we can continue to support them. And what BAR is about really changing that system to both support those students and to have the teachers identify the issue, not be the problem solvers, but be the ones who are seeing it, because we really need to take care of both our students and our staff, because that is one of the contributing reasons that people are leaving the profession, to see so many students struggling and not be able to help them. So I'm just really appreciative of this opportunity and excited. The other piece I wanted to echo, the state superintendent of Maine piloted this with 100+ schools last year. And I met with her a couple hours ago, and she's looking at a statewide implementation based on the data that she did with 100+ schools. So just know that you've got other states. North Dakota is also looking at doing that. So know that there's other states that you can look at, and in particular be able to say, here's what the impacts that we're wanting to be able to measure for both your students and your staff. But it also, that spread is easier that way too. I will say there's been a lot of educator who's been voluntold things, and it's much easier when you can take the willing and then continue to go from there. But I simply want to express my appreciation as well as really recognize the need to transform our systems, support everyone who's there.
Any comments, questions, committee for Angela? Seeing none, thank you very much, Angela. We apologize for all of our IT problems, but
Not at all. Thank you so
we're
much
working
for
on
this
it. Thank you
opportunity.
very much.
Yes.
Okay, committee. Let's turn to LSO. LSO, who's so quietly sitting there. Can you go back through and tell us what we've done terrible or good for you and what your assignments are?
Do we need to see if there's any other public comment before we do that? Or
I
I don't think there is. Okay,
Go.
I can go through then the tasks. So first, it's been requested that we write a letter to Management Council, basically giving a final report of what the task force has accomplished and wants to accomplish this interim. And then 25 LSO 103, which is the diversion or the treatment court amendments bill draft, that was passed and recommended to the judiciary with amendments. And then Chairman Larson suggested that LSO work with agencies to put the vulnerable adult essential services recommendations in letter form as part of the report that goes to Management Council. And then 25 LSO 216, which was the dementia care directives, that passed, and the chairman will decide who to recommend it to later. And that's all I have as far as tasks for us.
Ready? Oh, go ahead, Senator.
So, Mr. Chairman, because of where we are in the legislative cycle, Labor Health last meeting is next week. And the dementia care, that would seem appropriate to go there. If the chairman decided that it's not, I mean, there isn't an obvious committee to go to, certainly volunteer to take it up as an individual bill and work with other colleagues on the committee to assist with that. So anyway, I just want to throw that out there as you're looking at your schedule and what you want to do with that particular bill draft and the committee that it seems appropriate with. It could go to judiciary too, I get that, but
You're
anyway,
reading
thank you,
our
Mr. Chairman.
mind. Reading our mind.
Okay,
You guys.
I think we need that one. Know what the future of. Okay, anything else, committee? Okay, let's hit the road. Senator Barlow can go back to fighting fire.
Mr. Thurman, thank you for everybody coming here today. Thank you for all your participation. Thank you to PBS for assisting with the technology challenge we had this afternoon. Were not PBSs. They were URN, a very old library, the old Campbell County Library called the George Amos Memorial Library. So we're maybe didn't upgrade everything when we took it over as a meeting area. So anyway, thank you for being here. Thank you, Mr. Chairman, and thank you, LSO. Be safe going home. Prayers for all our first responders out there. Thank you.